On one hand, you hear all this talk about quality, but I mean, in reality, the needle in many areas of healthcare hasn't moved. In some areas it has, but especially on the billing side, the complexity's only increased. And so is there a future where that can be removed and so much of our GDP and tax dollars can be saved? Absolutely. But the inertia and the barriers to make that happen are pretty astronomical.
Healthcare isn't broken because of a lack of talent or compassion. It's broken because of the operating system behind it. My guest today is Dr. Reza Hosseini Gomi. He started in naval engineering, where precision keeps the ship afloat. He trained in neuropsychiatry, where understanding the mind is everything. Instead of choosing between engineering and medicine, he chose both to solve problems neither field could fix alone.
Although hands-on engineering was fun and I continued to work on projects like that throughout my career, I started to spend more time thinking about the systems we function in. How do you make any changes at that level? Quite a bit more complex. So I think the foundation of this sort of more tangible, concrete inner workings of things helped me unpack how things work and fast forward to healthcare, which I'm still figuring out.
As CEO of Medflow, he's quietly re-engineering the engine room of healthcare.
Medflow is really trying to represent some incremental baby steps, if you will, towards a future of proactive care, going towards incentives of the patient outcomes, value-based care.
Naval engineering is about precision in unpredictable environments, and neuropsychiatry is about human behavior, and even in more unpredictable environments. When did you realize those two ways of thinking could coexist and actually complement each other?
With working on the Navy destroyer, what was great was designing and building a new gun system for the ship. But then I had my own healthcare experience as a patient, and I was attracted in that direction. I just started to see that although when we were designing the Navy ship, we had a lot of control. It was a very large project and complex. It still paled in comparison to the healthcare system where you have so many different variables not really functioning together well, not really being examined. There was really no organizing entity over this system, so it kind of drew me in. How do you help and make changes to a system that there really is no glue?
Reza, welcome to Drug Diaries. There's a moment every clinician experiences when you realize the problem isn't the patient, it's the system meant to care for them. Healthcare isn't broken because of a lack of talent or compassion. It's broken because of the operating system behind it. The workflows, the processes, the architecture was built for a world that no longer exists. And while most people learn to live with that dysfunction, a rare few decide to rebuild the system itself. My guest today is one of those rare people. He started in naval engineering, where precision keeps the ship afloat. He trained in neuropsychiatry, where understanding the mind is everything. And instead of choosing between engineering and medicine, he chose both to solve problems neither field could fix alone. He built his first electronic health record in medical school. He founded companies at the intersection of AI, neuroscience, and digital biomarkers. And today, as CEO of Medflow, he's quietly re-engineering the engine room of healthcare. Not the glamorous part, but the part that determines whether clinicians thrive or burn out. In this conversation, we explore why the future of medicine won't be driven by more treatments, but by smarter systems. Why automation and workflow intelligence will define which organizations survive. And what health leaders still misunderstand about AI, value-based care, and the true bottlenecks in clinical operations. This is a story about purpose, identity, systems thinking, and one clinician engineer who looked at the chaos of healthcare and decided to rewrite the code. My guest today is Dr. Reza Hosseini Gomi, and I promise after this conversation, you won't look at healthcare the same way again. Reza, welcome to Drug Diaries.
Thank you. Thank you so much for having me.
Thank you. Thank you for joining us. So Reza, every time I meet someone who sits at the intersection of multiple disciplines, I'm always curious who they are when the labels fall away. Engineer, clinician, founder, neuroscientist. I believe those are roles, not identities. So before we get into the work, who's Reza beneath all of this?
Yeah, I think, it's a good question. And I'm at a period of life where I'm probably doing a little more reflection on that. It was easy from a young age to fuse my identity with work, with, what drives me where my passion is in terms of what I do day to day. But you bring up a good point of, you should always reflect on and think about what's driving you really and how to have a healthy balance with work, because obviously your identity is too fused, right? That can lead to a burnout of various sorts and, some bad outcomes for yourself. So that's something I've thought a lot about. I grew up in a very just kind of interesting environment where my family immigrated to the U.S. when I was still a small child. But unlike a lot of immigrants who, luckily in the U.S., there are a lot of pockets. You can often find, your diaspora and find your groups. But I ended up growing up with not a single person from the Middle East or anyone from my area at all. And so it was, what shaped me. It was a tough time growing up in terms of feeling like you belonged or feeling at home. There was a lot of friction, back then, the 80s and early 90s. And so, I think I just got lucky. I think I ended up in some really good places, good mentors, good teachers. My parents were both working constantly. So I really actually didn't see them a whole lot. I'm kind of growing up. And so I think that ultimately what helped drive me to sort of be where I am today and wanting to just sort of fix problems for other people is just seeing the challenges other people were going through and trying to, give back in a way. But ultimately, a lot of what drives me is trying to have some sense of control over my environment. And growing up without that sense of control, it leaves quite an impression on, when you're young.
Yeah, that's a great reflection. And that made me think it is true that when you grow up in an environment where there's less control, that triggers you intrinsically to make things better when you grow up. So thank you for sharing that experience and reflection. And I read once that we spend the first 10 years of our lives absorbing and the rest of our lives unpacking. So your journey from naval engineering to neuropsychiatry suggests that you are someone who sees patterns beneath complexity. So what early experiences shaped the way you think about systems, people, and purpose?
Yeah, absolutely. I think from a very young age, I liked, I would always take things apart. I wanted to know how things worked. So I remember when I was a kid, which my parents weren't always very happy about, they would come home and, the TV was taken apart.
Oh my God.
The radio was taken apart, something would be in pieces on the floor. So, early age definitely had this sort of natural attraction to just how things worked. And then as I grew, it expanded because I came to understand that although hands-on engineering was fun and I continued to work on projects like that throughout my career, at the end of the day, like you mentioned earlier, we were sort of all functioning in systems, many of which we weren't even aware of or necessarily knew how they came to be or how they worked. And so I started to spend more time thinking about that, the systems we function in, and how do you make any changes at that level? Quite a bit more complex. So I think the foundation of this sort of more tangible, concrete inner workings of things helped me then start thinking in a systems way of really trying to unpack how things work and, fast forward to healthcare, which I'm still figuring out.
Right. And, most people choose a lane and then they build on it. But you chose two, which have got hardly anything common between them. Naval engineering, as I understand, is about precision in unpredictable environments. And neuropsychiatry is about human behavior and even in more unpredictable environments. So when did you realize those two ways of thinking could coexist and actually complement each other?
That's a good question. That first job I took out of college felt like a natural progression because with working on the Navy destroyer, what was great was designing and building a new gun system for the ship. It gave me the opportunity to have to interact with, the rest of the ship systems. We had to, obviously plug in and work well as part of the system, but we also were building its own system, zoomed in level. And so that was much more the traditional, in terms of engineering problems, systems problems. I had to learn to think at a systems level. There was a lot of quality, QA work that relied on that. But then as I became interested in healthcare, had my own, healthcare experience as a patient, and I was attracted in that direction, I just started to see that although, when we were designing the Navy ship, we had a lot of control. We would all step in the same system. We would design all under the sort of same umbrella. And so we had a tremendous amount of control. Although it was a large, very large project and complex, it still paled in comparison to the healthcare system, where you have so many different variables not really functioning together well, not really being examined. There was really no organizing entity over this system. So it kind of drew me in. How do you help and make changes to a system that there really is no glue? It sort of works, but it mostly doesn't. And so it was an interesting problem for me. And I figured, man, I could really spend my whole career on this and maybe try to make some little dent. But it's a humbling problem to look at.
Indeed. You're spot on. And I hear this from a lot of founders coming from medicine. One moment when they realize the system is failing, not because of medicine, but because of the workflow. Did you have a moment like that? Maybe a patient, a failure, a bottleneck, where you thought, I can't just treat patients. I need to fix the system behind it.
Yep. Yeah, absolutely. As I had my own patient experience, that definitely was a breaking point for me, where it really presented a fork in the road and made me want to pursue healthcare, but find a way to combine, engineering and practicing. I mean, that was just going through the system. I had some, big hard lessons learned through both insurance companies, but also delays in diagnosis, how difficult it was, the advocacy I needed, the side effects of things that happened. So I kind of checked a lot of the boxes. Unfortunately, a lot of people do experience once they're heavily involved in the healthcare system. So that was, in my very early 20s. But then later, as I started gaining experience with patients, and then even in medical school and beyond, as I was involved more directly in the care and the diagnosis, I would have patients that would say, we would diagnose with, for example, with dementia, and they would ask me, what do I do? Tell me what comes next. Like, how do I function? Like, where are the resources? All the normal questions. But in that system, we were just monitoring decline. We weren't giving them much of a plan, no real treatment. And so that's, really heavily when I realized the system was designed to not help people early enough to matter. And so that was a big motivator, is just seeing specific, some patients, and many stand out in my memory, but going through that experience and thinking, man, there's got to be a more proactive stance here.
And Reza, the average clinician spends nearly twice as much time on admin as with patients, and most complain about it. And you, for some reason, decided to built your first electronic health record in medical school. Mm-hmm. What did you see that others didn't?
Yeah, at that point, we were running a series of 6 free clinics, six nights a week in various locations around the region. And, we were doing the traditional paper charts. And so it was both an interesting platform for me to see if, was there some improvements to make here? But also I had some unique design features and requirements. Because we were free, taking out the entire insurance framework and the payment framework massively reduces, that's the largest load on any of these systems, in terms of how complex it is. So that really felt like it took the, chains off and let me design something like kind of the sky's the limit. And luckily I had a great partner in terms of a company that put the resources behind it. And we built something at the time, which was, my goal was, what's this, an interface where whoever's using it has to spend as little time as possible using it,
Right.
Essential information is captured quickly as possible, and the rest, they're looking at the patient. And this was before AI and all of that. So this was about 2010. And so we built that out. We went live with it. And, that's when I started learning a lot of lessons. Even though in my mind we'd built this great thing, there was so much friction with rollout. A lot of people, we had a lot of the volunteers were folks who've been volunteering for years. They were retirees. They're like, wow, I don't want to learn something new. What is this? Why do I need a computer? Why do I just like, scribbling a couple notes on paper. So a lot of lessons like that, were learned during that rollout, but it was overall just a big experience, in terms of building something, doing user research, going through various iterations, A/B testing, the deployment, the transition, and so on. It's a massive undertaking. Even for where we were a bunch of free clinics, it was quite an undertaking.
Right. And when I look at your career across Neuralex or digital biomarkers, cognition, and now MedFlow, I, I see a deeper theme. It feels like you've been studying systems your entire career, whether neural systems or healthcare systems. Is that a fair assumption?
Absolutely. I'm a very systems-oriented thinker. If you present something to me, I want to look at the 30,000-foot view first, and that kind of hone in. And so my head always goes into systems mode as a kind of a default.
Right. Okay. And Reza, there's a statistic I keep coming back to. Healthcare is 18% of US GDP, but 25 to 30% of that is administrative overhead.
Yeah.
And yet workflows, the thing that runs everything, get the least innovation.
Right.
How do you explain MedFlow's mission to someone outside the industry?
Because so much of healthcare is spent on administrative tasks, there are a lot of entrenched, incumbent providers of these that benefit from these administrative tasks. So there's not a lot of incentive for the systems to change, right? I mean, insurance companies and others have the most powerful lobby groups in the country, and that's the case in many countries. And so there isn't a lot of incentive. So you have to be very careful. You have to understand that from, again, the high level really helps because you're going to run into barriers. If you're only looking at, some software and some code and you don't think about those barriers, you can't make any progress. You won't get anywhere. So when I really zoom out and I see how much of it is being used, MedFlow is really trying to represent some incremental baby steps, if you will, towards a future of proactive care, of going towards incentives of like the patient outcomes, value-based care. And so where we all, myself and my colleagues, we came together was through many of our own personal experiences, but also just the themes we saw professionally over the last, 10 plus years.
Right.
Of what is the challenge here. I mean, on one hand, you hear all this talk about quality, but I mean, in reality, the needle in many areas of healthcare hasn't moved. In some areas it has, but especially on the billing side, the complexity's only increased. And so is there a future where that can be removed and so much of our GDP and tax dollars can be saved? Absolutely. But the inertia and the barriers to make that happen are pretty astronomical. So we know it's something that kind of the whole industry has to work together on.
Sure. And every time I speak to a clinician, they say that it's a death by 1,000 clicks.
Yeah.
But systems seem paralyzed. Why is workflow one of the biggest problems in healthcare and also one of the most ignored?
Yeah, you get a combination of good enough workflows in healthcare specifically. Often people haven't even thought about the workflows. So then when I go talk to a customer anywhere I even work and ask, what's your workflow for X, let's say for patient admission, they generally can go over the basics, like these are the steps, you got to click here, you got to add this to their record, you got to scan this and so on. But if you just go one step further and say like, why is it that way? Does it have to be that way? Most people, right, they're just trying to survive, get through the day. They haven't really thought about that. And so it's just giving that moment of pause of, wait a second, you just described 15 steps. Does it really need to be 15 steps? Could, 14 of those be automated? Oh yeah, I guess it could. And so a lot of conversations like that happen and people realize pretty quickly. I'll give you a good example that's kind of playing out in real time right now. In the insurance world, there's a reason why insurance companies do a lot of denying, right? It's built into the system, right? It's like rebates, like they don't want you to be able to collect so they can keep their margins. So they have to introduce, they're incentivized to introduce some friction, right, to the process of getting reimbursed or having a procedure approved or medication. And so when you want to call, you are forced to call. You can't do it online. You can't just go on a simple, quick form and fill it out. They make it difficult. So you got to call, you got to wait on a phone tree, right, and all of that. Well, now what we're seeing is there are a number of AI tools, AI voice tools, where they'll have an AI voice agent call the insurance company for you as a provider or patient and take care of the call. And it's so good that, the insurance agent has no idea that they're talking to AI. But that now starts to defeat the purpose. The point of the phone call, right, was to make it difficult for the human. So if you take that difficulty away, one thing I was anticipating is that soon you'll have AI talking to AI, right? Insurance companies will use their own AI voice agents. And at some point, will that continue? Will that become obsolete? Will they realize, well, this game of adding friction is sort of meaningless now because humans are involved? So you're seeing that play out in real time. That is live. That's happening today. But until you really ask the question of how did you get there? Why is that process the way it is? And, what can change it? you sort of get these complex layers added. Now we got AI agents
Mm.
making the silly calls and all that. Whereas we need someone to question the whole thing in the first place, right? Why are we even having these phone calls?
Yeah.
That's kind of like just an example of how things can get complex over time, and then you end up accepting it as a status quo, and before you know it, it's become standard.
Wow, this is truly enlightening for me because I've got very little idea about how the healthcare system works in the US. So thank you for sharing that
Well,
example. That was very helpful, actually.
very good.
And most automation in healthcare feels like patchwork, fixing symptoms instead of architecture. How do you avoid that trap?
That's a really good question, and I think it's a tough one. I've been in that trap many times, and I think with what we're doing now, it's very easy to fall into that trap. So in parallel, the relationships, we always say healthcare moves at the speed of trust and integration. It does not move, any faster. So it's not the kind of field you can walk in and disrupt, despite, what all of us would like to do. And so that trap of working on something and being a little bit too narrow-minded, a little too myopic, and then realizing, oops, I've been working on the wrong problem, or, something changes in an adjacent system and makes that problem different or obsolete. So it's hard. And I would say it's pretty, you can only do so much risk, control on that, but trying to build the relationships with all the players involved, trying to go in with the same sort of mentality does help, so like in our case, being friendly with insurance companies, being friendly with the payers, the billing companies and so on, the EHRs, so that we can at least work hand in hand. I think you really have to do it that way. Otherwise, for example, people come up with tools all the time. So you might release a new test on the market, and let's say a cognitive test. There's a billing code for it. You automate it. You build a workflow in your EHR, and great. And first couple months go by, and more patients are getting it. Well, if you haven't built relationships with payers and they don't want to pay for that, naturally they're seeing a line item for them going up, a cost center going up. What are they going to do? They can just blanket say, we're not going to pay for that test anymore. And then all of that work is down the drain. Whereas if you come at it ahead of time, build a relationship and say, listen, you're going to see some increased cost up front, but we have this data over long-term savings. Your patients will get sick less. They'll spend less time in the hospital. Then all of a sudden now, you can build that tool and avoid some of that friction. I've seen that happen many, many times with many companies that will build a solution, but they haven't built the relationships across all the affected parties. And like I said earlier, there's a tremendous amount of inertia in healthcare. It didn't get to where it is overnight, and so you're not going to change it overnight. And if anyone has a delusion that they're going to, force or change an, insurance company's practice, I mean, please let me know how you did that, because, I will, it's kind of impossible for a reason, right? So that's just another example. It's very easy to fall into that trap.
Right. And Reza, you integrate with systems like Athena One. And how do you decide what to automate, augment, or completely rebuild?
Yeah. And so it's interesting. We accept that, the entrenched EHRs, the large ones, the ones that have been around for a long time, so the Athena ones, the Epics, the Cerners, the Next Gens, and so on, they're not going anywhere. Change, as you say, some folks may have been following, for example, Cerner won the VA contract a few years ago. This is the Veterans Administration. So this is one of the largest healthcare contracts you can win, if not the largest in the U.S., because it's an entire chain of hospitals and healthcare facilities and outpatient and tons of stuff that take care of our veteran population. So it's a very large network that's actually under one roof. So this was a highly competitive bidding process. Epic certainly was very, very motivated to win. Cerner ultimately won it. But that's, these are 10-year contracts. It takes many years to bid. So things aren't changing anytime soon. Although I've seen a number of announcements and, okay, we're making some AI-driven EHRs. That's great. And there's some growth there. But it's still, we're talking low single-digit percentile, right, of the market. It's a very, very slow growth. So to answer the question, we accept that that's part of the market. That's why we're really working hard on those relationships, to have healthy relationships with those players. And it's kind of a combination of rebuilding and improving. So we're accepting that, this partner is going to be part of the picture. So what's
Mm.
the best we can do with them in the picture rather than like assuming a full rebuild, which is possible in certain scenarios because of where we are, because of the proliferation of out-of-pocket pay subscription, type of membership models, the sort of direct primary care, concierge care, longevity. There are an increasing, although small, but increasing number of people that are paying for healthcare and just leaving the insurance system,
Mm.
leaving the Medicare, Medicaid system. Again, a minority because it's not at an insignificant cost. Well, for those types of systems, we are able to build really with, just like in the free clinics, I had many years ago, without all of that complexity, we're able to rebuild completely because they
Right.
don't need to use traditional EHRs. So it depends. The majority of the market is mostly an improvement and build on. And then there's a minority part of the market where I do think you can feasibly rebuild.
Right. And everyone talks about value-based care, but very few operationalize it. Most systems spend millions trying. And you've said this before, that automation can make the economics finally work. So what are people missing?
We've watched for now upwards of 2 decades on various iterations of value-based care, places along this risk spectrum of how much risk is taken, how much shared, upside or downside, we call it, meaning do you get a piece of the pie if you do well versus do you take some of the loss if it doesn't go well, sharing with the payer. The vast majority have failed, and that's because it was inevitable. It was never feasible to take on really much risk at all
Hmm.
when the payers stand to benefit and have all the power. They have all the insight. And so, for example, I'll give an example of a failed model. A large neuroscience group came in, signed a value-based contract with a large payer, and said, look, for this whole region, we have a few 100,000 patients, and in this region, we will take on some risk. So if our patients do better, we'll get some bonus. And if they don't do well, we will take a little bit of the hit, so meaning, if you lose some money, we'll share some of that loss. But that's a big risk, right? If it goes well, great. But if it doesn't, there are very, very few organizations in the US that can really take much of a loss at all. And so much of healthcare in the US is used to operating in a deficit, in the red. And we get subsidies, we get tax dollars, we get donations. So we've been in this just very awkward gray zone of healthcare is both a business. There's a for-profit version. There's a nonprofit version, right? There's a government version. And where are you in that? And where does value-based care live? Can you do it as a for-profit model? Not really, not yet at least. But when you bring in automation, you're now all of a sudden able to cut out a lot of the margin wasting stuff. So a lot of the complexities on the billing side, and just to put it in perspective, for folks that get their healthcare out there, you can think of a large system you go to get healthcare. They have buildings just filled with people to do things that other industries just don't have. They're like phone, call centers, just huge building of call center type of people for things. If you just had a decent online scheduling, you could just do it there, but they have call centers. They've got, enormous groups of billers, people that have to go through and do a lot of manual work on just to make the payment process. In other industries, we've got the Stripes of the world, right, that have blown up and you don't have anyone. I can start a business today and have 0 people that are responsible for billing on my company, and I can capture tens of millions of revenue with nobody other than a part-time accountant. In healthcare, if you're talking tens of millions of revenue, you probably have 50 plus humans sitting there just clicking buttons to make that process work. So just to put in perspective, it's a real outlier. I don't know of another industry in the world that requires so much hands-on for something that's been figured out in other industries so long ago. So I think you have to be able to remove those really eat into any kind of profit or any margin, as you have to really be able to remove those. Otherwise, I just don't see how value-based care can work.
Right. And looking at it from the health system's perspective, automation isn't a sexy story, but ROI is.
Yeah.
So what metrics truly matter for CFOs and clinicians? How do you measure ROI and return on health when selling automation to health systems?
Yeah, that's a really good question. It can take a few different shapes depending on the audience. We have a few different, types of audiences. So we have health systems of different sizes. We have smaller clinics. We have a pharmaceutical industry. So depending on the customer, it's really important to know what moves the needle for them on the financial side. There are health systems that are involved in some sort of like quality-based or value-based contract. And so being able to move that needle can be very incentivizing. So they might say, well, we get a quality payment if we reach 90% on this metric. And the metric might be number of people on their Medicare Advantage plans receiving an annual wellness visit. That's a very common one in the US. Well, if they've been struggling, which is very common, it's hard. These are all things we take for granted, but thinking you can get to 90%, but then all the nuances right in your population that prevent you from reaching that come into play. Well, if you can automate some systems, help with outreach, help with scheduling, help with insurance intake, all those 100 steps, you can help them approach that. So that's one of that could be an ROI right there. They reach that, they get a big payment, they're happy, and you can share on that upside. For the reality is, for a lot of healthcare providers, they're still in the fee-for-service world. They do something, they get paid. They do something, they get paid. It's reactive. And so what we're trying to do is still improve those processes so they can do more of those things, make more, see the ROI in real hard numbers, but try to focus on doing more of what helps patients rather than doing more maybe of things that are not as, value added. So, like doing early cognitive screening, for example, for populations to prevent long-term, care issues, using reimbursable type of events. That's helpful versus, maybe increasing the prescriptions of something expensive that maybe there's an easier alternative for, So at the end of the day, we work together, but we try to show the path towards a value-based care world. So the ROI is different. It could be, again, capturing patients for pharmaceutical. Often it's, clinical trial enrollment, identifying the right patient, increasing some kind of fee-for-service activity, kind of performing on a value-based care type of metric. And the payers are incentivized too. You can often find a win-win because payers, right there, they have star ratings in the US. They have like kind of ways that they're given a rating on, and some of it's based on their customer member satisfaction. Some of it's based on certain quality measures, like does a certain percentage of their population get an annual, blood pressure check, or after they're hospitalized, does someone talk to you within 7 days of your hospitalization? Right. So being able to do all of those things, all of those are automation can be very helpful.
Right. And everyone's talking about AI, but
yeah,
most deployments are shallow, disconnected, or generate more work. For someone building in the trenches, what's hype versus reality?
It's an interesting question. There's certainly a lot of hype. Right now, it's tempting, to kind of put AI or AI powered or AI first on just about everything. I think, technology is part of the solution, but it's the infrastructure, it's the plumbing. Nobody goes to the hospital because they have great plumbing, right? But if the plumbing doesn't work, they're in trouble, right? The hospital's not going to be open. And I think it's the same thing with healthcare. It's still about the people. You have to be able to enhance the people. And their ability to spend more time with patients, their relationships being better, that really is where AI can help. So that's, that's our thesis. We're really focused on more of it behind the scenes. But I see a metric of if the provider, any healthcare worker, it doesn't have to be just a provider. I mean, anyone can spend more time looking at the patient than looking at a computer, then we're winning. And I think that's where you kind of can see it. But where it's probably overhyped is saying like AI is going to help take over diagnosis or like a lot of the patient facing things. Is there a future where that has a role? I'm not going to say no to that, but I think it's much further than people might think. Is there some capability? Are there some numbers that show like in certain controlled settings, AI does a better job of diagnosing something versus humans? Sure. But again, reviewing that data, I mean, there's a lot of nuance missing from that. Where the AI does break down in real settings, in kind of just in the wild. It's going to keep getting better, but I think the patient-facing AI stuff, I would say, is just generally overhyped right now. I don't see an immediate application that's going to do well at scale.
Right. And when you talked about diagnostics, the role of AI in diagnostics, it reminded me of this experiment that recently took place in Shanghai at Medical AI conference, where the doctors were asked to compete against AI for the diagnosis of gastrointestinal condition. And I think while the doctors took 13 minutes to diagnose, AI was able to do that in 2 seconds, because just reading through all the papers took them 10
Yeah,
minutes.
right.
So yeah, it's a pertinent and very relevant discussion that is taking place right now.
And in that example, what I might suggest or sort of posit is that the role of AI, my conclusion is the role of AI is summarizing and delivering the right information for the provider, versus many are coming to the conclusion that, oh, AI should make the diagnosis. I don't agree with that yet, because again, there are a lot of nuances that if I gave that AI a human, a real human that was speaking to it and, kind of doing what humans do, patients that are upset or, there's emotion involved, they're rambling, there's data all over the place. It's really good at summarizing, but there's a lot of distractors and nuances that can lead to the wrong diagnosis. But again, that's going to get better. And I think certainly can be helpful with summarization.
Exactly. I think the way I see it is that AI will replace tasks, but not humans.
Yeah, that's a good way to say it.
And I like asking founders this. Imagine you had a 10-minute meeting with the CEO of a major system. What 3 things would you tell them to prioritize in the next 3 years?
With a healthcare CEO.
Yes.
So I think the biggest 3, and this is one that some of these are ones we come up against in terms of our own, like trying to get MedFlow out there and selling. I would ask CEOs, really think about when you buy a piece of software often or technology, it might have really good ROI, in the marketing materials, but really ask, is your clinician's job going to get harder or easier, as your end user? And if the software is going to help you capture more revenue, but it's a lot more clicking or a lot more data entry for it to work, it's not integrated well, so you have to bring over all this data and it's a Herculean effort, maybe second guess that, is there some short-term gain maybe, but, is that going to be the right thing? So I would say, look at the technology and what makes the life harder for your workers. I would say definitely invest whatever level of workflow automation, but think about workflow automation before you try to invest in some kind of like next AI fancy tool that's more clinician or patient facing and getting involved in clinical workflows. Often come down just one step, just basic automation, even just like an if then, right? If patient presents with this, do this. That can often move the needle operation, because what happens is a lot of times CEOs don't see that their core systems are broken. And so bringing in AI to a broken system is not going to fix the system, right? You have to really fix your operations first, and then you can bring in new tools and add layers. But we don't often get that right. So that's number 2, really think about fixing your systems and just introducing some automation incrementally. Maybe third, when you're thinking about value-based care, which to some degree everyone is, think about really implementing, and it could start at just a small level, talk to your payers or do it internally. Forget about the payers and just do it for yourself, but perform on some kind of quality metric at a starting point. But you just got to jump in. You got to do it. You got to try it rather than just talking about it. Cause I think the vast majority of what I see out there, it's talk. Most people, I would say over 90% are not doing anything on the value-based, but boy, they will come to conferences, sit on panels, right, and talk about value-based care, but talk to their patients. No one knows what they might be referring to. So I think ultimately seeing that margins can be in prevention and care gap closure is motivating. And sometimes you just have to sort of start, just like I would tell a startup, in a software startup or any startup, start small. Pick a solution, bootstrap early on and get it in the hands of some people and just see if, it's working. There's traction. It's the same idea in healthcare. We just have to not get overwhelmed by how large and how complicated the system is and not wait for everything to be perfect. I got to talk to these payers. I got to get this contract in place and so on. Pick 50 patients and see if you can move just one outcome for them, move one care gap. And that's how you can get started.
That's a great piece of advice. And thank you so much for that. And I see so many founders built for ideal workflow, not the messy real world. So, Reza, what mistakes do you see repeatedly in digital health innovation?
Sure. It's a really great place where you have so much energy in health tech from folks that are coming in. I think some of the mistakes, one is there's a gap between practice, the experience, and then the solution side. You get a lot of excitement, a lot of people that might have one personal experience that's motivating, or they might just see something that's wrong and think, okay, I can fix this in healthcare because I was able to fix it over at Apple or Google or one of the other companies. So there's a bit of sometimes a disconnect in understanding of healthcare is a different beast. Certainly it needs those people, but it's just not as easy as, we got some, we went to some kind of accelerator and we did this and kind of shooting for the moon. Healthcare often, you benefit the most from very incremental, very smaller, changes initially. There are some exceptions to that rule, but very few. The vast majority of successful, health tech type of startups are very focused. So I'd say that's one, just kind of the incremental focus versus, we're going to disrupt the whole industry. Number two is making sure you have a well-rounded team. I'm surprised still how many teams I see that don't have any clinical experience and have no clinician or anyone in that sort of clinical infrastructure. And I don't mean like, an advisor you talk to once a month. If you don't have someone core to the team, I'm hard pressed to point to many successful companies. I mean, most of the companies that have been successful have a clinician as one of the founders or very close to that. And so I think just keep in mind, I wouldn't take for granted how difficult and complicated healthcare is and how much it relies on the relationships. So that's another one. And then as you're building tools, the third one is, it's tempting, just like in other industries, you're designing for like a TechCrunch headline, but the reality is your end user, your product might be reliant on a 65-year-old physician who's seeing 30 patients a day and doesn't have time, to really have to learn anything. And so just remembering who that end user is, just because it's something that works for your group, doesn't mean it's going to work right for others. And we've seen this with even with AI, for example, right? There's massive bias in AI. I remember when transcription came out, some of the transcription tools, and it was kind of embarrassing for some of the companies because it could understand, people who worked at big tech companies in the Bay Area well, but it couldn't understand people like in Alabama or Texas or lots of other places, right? And you see that over and over again. You want to build the populations you want to serve, and so you have to go that extra mile and find users and testers that represent those populations, not the easy, your colleagues in the building. You can't really judge traction based on, a healthy 28-year-old software engineer saying, oh yeah, no, I'd like this. I'd like to use that. We saw Amazon did that with Amazon Care. Right?
Yes.
They made their whole decision on going live nationally, coming out of stealth mode based on the fact that a small group of their white collar employees in Seattle use the care system. It's a very interesting conclusion. Of course, it did very poorly and they shut it down. But we see that over and over and over again. So that's definitely a lesson, let the big companies learn the expensive lesson, but for small ones, we can't afford that.
Yeah. So in conclusion, what will separate winners from the losers in the next 5 years, let's say?
Yeah, I think certainly one is being really careful about spend. It's okay to bring in VC dollars and investment, but be very lean. I wouldn't overspend. I wouldn't over rely on marketing too much, especially like the direct to consumer sort of like social type of, the ad companies are very rich for a reason. If your product can't turn around and have a life cycle that's short enough, well, then you're not going to be able to keep up with that. So I would say, people that are really good about spend, really looking at fundamentals, they have their P&L front and center, and they're looking at the finances and making sure that they have a long enough runway. And in healthcare, your runway needs to be really on the years, like 6, 12, 18 months is just not long enough for meaningful growth. And before you know it, if you keep that spending up, right, you're in cycles of fundraising and dilution, and it just makes it harder. So I would say that's something in common there. Another common theme is just really good work across verticals. So while being focused on a solution, having relationships across all the players, talking to the payers, the providers, the health systems, and so on, and just building those relationships. I would say those are two relatively common themes I see in the successful companies.
Right. And I've noticed that founders who work inside broken systems often go through inner rebuilding too. So what did you learn about yourself in the process of building MedFlow, and what has entrepreneurship taught you about yourself?
Yeah. I'm certainly not naturally good at letting go. I definitely, over historically, I would have this urge to solve everything myself. So kind of building a team, making sure folks are in the right roles and the skills are aligned, enhancing those strengths. That's been a big thing. Really, I mean, the theme here comes back to the people, the
Mm,
relationships. So I'm not so much, we use AI, of course, and it's integral, but what makes or breaks it is the people and how you manage people, because that then everything else rests on that. Are you able to pivot? Are you able to, learn from your mistakes? Are you able to see that, something's not working, make a change? That really has to do with the relationships and the people. And so I really, especially being in the role I'm in today, I view myself as I look at my team, what are the blockers? And I just try to remove their blockers. So when I'm talking to folks every day, it's really my concern is what's keeping you from getting to this point that we've
mm,
identified as strategically aligned. And so that's kind of where I've transitioned to, but sort of, yeah, striking that right balance of being hands off, but not too hands off. That's been the hard part for me.
right. And where do you draw your inspiration from outside of medicine and technology?
Well, it's a good question. Certainly all the stories, the people, I've have constantly, I receive stories in person, people in my life, but also, via LinkedIn or other outlets, I'm constantly hearing some stories that are very motivating, many tragedies, many, some success stories as well. I also, I love reading very like science fiction and
Right.
kind of fantasy type of genres. That's sort of like my guilty pleasure in terms of like, when I want to kind of unwind. And in that, it's just kind of stoking the imagination. It's just letting you like, man, like look at these alternate realities and universes and things that are possible. And again, it's sort of like that ultimate zoom out, right? Like think about how small we are in the universe, and just thinking about those things just can, make give you quite a bit of perspective pretty quickly. So that can help too, just like
Good.
as much as we focus and working on even healthcare and how difficult and complex it is, but then still thinking about what a small part of the universe it is.
Right. Like E&M Banks kind of books or,
Hmm. Well, yeah, honestly, yep. Ian
yeah,
Banks, and yeah, I mean, I'm not too picky. I definitely have some favorites more on the fantasy
would
side,
love to
but
know. Yeah. Love
yeah,
to
the
know a
science
few
fiction.
suggestions.
Yeah, I mean, so on the fantasy side, like historically, Patrick Rothfuss, I thought, has written
Mm,
some really great books. Of course, like, it's funny, I read Game of Thrones. I started reading it like in the 90s,
really?
the late 90s. It's kind of, I can't believe it's been that long. So when it was really just books and it was, it was building a following, that was back then. But I'm trying to think of, well, what did I read recently? A little more on the science fiction side, but I'm not like necessarily, I often will find an author and sort of like, try to see what else, but then inevitably I
Mhm.
get fresh, like, and the good ones can take their time, and then I get fresh.
Yeah.
I'm like, oh, come on, write some more. But I think that, yeah, I'm trying to think if there's a common theme. It's really, yeah, it's more about like I guess the ability to kind of use your imagination and daydream a little bit, I
Right.
guess is kind of what it is. But yeah. So really anything, and I go off of, I mean, if you have any recommendations, because that's mostly, I'm almost exclusively just read what people recommend.
Yeah. I think I'm right now obsessed with Ian Banks. And
Yeah.
that's what I've
That's a
been
big
reading. That the whole series is so fascinating
Yeah.
and such an amazing read.
Yeah.
So I'm kind of absorbed in that right
Okay.
now.
Excellent. Yeah, he's quite popular right now.
Yeah, yeah. And if we zoom out, Reza, what is the legacy you hope your work leaves behind?
Sure. I would love to be able to like look back and see that the needle moved, that patients were impacted, that, something improved. With some of my previous work a couple of years ago, we published a paper showing, some significant hospitalization rates reduced in our system of care. That, that's very gratifying. That's,
Mm,
I want clinicians to have an easier time taking care of patients. I want to be able to like, again, measure that and see that and say, clinicians feel a little bit better. They're spending a little more time doing the things they want and then less time not doing the things they don't want to do. And so like those are definitely two biggest buckets, like the impact on patients, impact on providers. That to me is like, and again, I don't have necessarily like a specific like category or number, but I mean, certainly just being able to see something that's measured is I guess my ultimate goal.
And what's one belief you hold about the future of healthcare that most people strongly disagree with?
Yeah, I might go as far. I mean, I could even say healthcare doesn't need more innovation right now. I think it needs better implementation. We already know quite a bit of what works. We're just not implementing it right. I mean, if I would argue, if we could get populations the care they needed, and a lot of it is, education and motivation, a lot of it is those systems. I honestly think the average age could easily be well over 100 of populations. I mean, I think we're 20, 30 years of age behind where we could be easily. I mean, that's just doing the things we know today. We don't need any new technology cures to make that happen. Certainly, I'm very supportive of scientific research, and of course, so that's not that, but so I'm not trying to take that away, but just the impact we could have on what we already have, I think is highly underappreciated. And so I think it's very tempting to say, we need that new drug, we need that new invention. And please, I'm a huge supporter of scientific work. I'm a scientist as well. But again, what we already know would make a bigger impact in almost any, new individual treatment. And so that's just one thing I would call out. And, I think there are things about healthcare that make it unique and different. But at the end of the day, when I talk about healthcare and operations, it's a service industry with operational problems. It's the same as restaurants, the same as everyone else. And so we need to approach it that way as well, rather than, looking for Hail Marys and cures, I think at the end of the day.
And I see your posts on LinkedIn, and they are incredibly insightful and inspiring. And they are mostly around neuropsychiatry. You talk about Alzheimer's, you talk about Parkinson's, dementia, and you've got a massive fan following. So is that something you still practice, neuropsychiatry?
Yes.
Yeah.
I'm pretty stubborn about that. I see patients on Tuesdays. I'm in the process of opening a larger facility in the Boston area for my patients, where it'll be a lot of resources all in one location. But absolutely, I'm a big believer in being hands-on and staying really close to the work that motivated me in the first place. Right. I know not for everybody that's the case, but I do think, again, going back to the comment about having some clinical experience on your team or stay close up, I do think that's important.
Right. And that brings us to the end of our today's conversation, Reza. Thank you so much for joining us and for such a candid, deeply thoughtful conversation. And your work at MedFlow is reshaping how medical teams operate. And today you've helped us understand not just the technology, but the intent behind it. And for our audience, we talk a lot about innovation on this podcast, but what we heard today is a reminder that progress happens when the right people tackle the right problems with clarity and conviction. So Reza, thank you once again for bringing that spirit to Drug Diaries. And to everyone listening, thank you for spending your time with us, and we'll see you in the next episode.